can refer pain in the buttock, in the deep pelvic area, and it can radiate pain all the way down to the heel, in the posterior thigh here. But the sacroiliac joint is very, very stable. There's only about 3 or 4 degrees of movement, rotational movement in it. And we see them mostly with instability, with pregnancy, and women who are hypermobile. And there they mainly need some stabilization with belts and muscular therapy. But if you have a sacroiliac problem, a locking or an inflammation, when we go down to L5 here, you've got the pelvic rim. And when you follow that all the way into the sacrum, you'll find 2 small dimples here. And you can actually palpate the sacroiliac joint on the top. And it's always the top of the joint which has more movement and where you'll find the irritation. So how do we actually isolate that joint? It's quite hard. A test has been installed where you compress the hips, put distraction in the hips, but we also irritate the low back spine and we actually stretch the muscles. So what I recommend that you do is that you take slight flexion of the knee and then you go straight over the joint. And then you compress it while you lift up. You actually try to cause rotation outwards, and see if that reproduces the pain. If you've got a true sacroiliac joint problem, it will explode everything you do. It's not enough that it feels a little more blocked on one side, the other side. That's mainly just due to muscular problems. So you can differentiate that very fast. While having the patient lying here, the iliopsoas is very, very, very important and undertreated too, because you can't get to it. So how do we actually diagnose it? If we have a higher level lumbar disc lesion, it can mimic the pain too. So what I want to do is rule that out first, and then I want to stretch to the iliopsoas by holding the hip down and putting the leg up passively to see if that reproduces any pain. So I'm stretching the muscle. It's non-specific, so it's quite hard to do. Always passively look at the motion of the hip while they're lying down, both in the prone and in the supine position of both legs. Lying back, please. Back. Wake up. You have to be very, very careful with hip pathology. You have to rule out femoral acetabular impingement. You have to take x-rays and sometimes MRIs if you are suspect of it. So you check for full range of motions of the hip, flexion, extension, medial, lateral, rotation. You're going to do the fadia test, and test down the joint to see if there's any pain. Okay. If you got a sacroiliac problem too, you can actually reproduce that. So you go in and put your hand under the sacrum. So you push it all the way until you got your palm of your thumb under the sacrum. You put your leg up here and you press up on the sacrum while you press down on the leg to create a shear force on the sacroiliac joint. That's the most specific test you can do. But you have to use a lot of power. It's a very stable joint. But then again, if you've got inflammation of the sacroiliac joint, they will scream when you do it. It will be very, very painful. The iliopsoas, how do we get to that? So the trigger points are at the most often just lateral to the attachment of the lumbar spine, the transverse processes, and then you find them here just superior to the inguinal region here. So normally I would have the patient lie with a cushion. Have a back or cushion? There's the cushion. So I place a cushion under the legs here, so they actually have the legs up here, and so they can relax the abdominal cavity and the abdominal muscles. And then you go in, and if you're in doubt, not good at palpate, you can always go lateral to the umbilicus, just lateral, about 2 or 3 centimeters. You'll find the intersection between the rectus abdominis and the iliacus. And then it's very important that you have the patient lying with the legs up so they don't have any tension in that at all. And you go in deep, really deep with 2 thumbs. You go lateral to medial, and if you just give time and let the patient breathe, you can actually palpate the transverse process in here. Good. So you have to take it in steps. You have to be right in the junction between the rectus abdominis and the oblique muscles here. And then you have to give time. And breathe normally. Breathing out. And you will sink down even further and further. pulse again. And here I'm on actually the attachment, just proximal for the attachment of the ESWT, the top here. And if you've got a trigger point there, it will radiate all the way around here. You can address it from the posterior side, you have to go anterior again.
Can
So
you do that one straight on the other side?
Yes, I can illustrate on the other side. So it takes time to get into the tissues, and you have to get the patient breathe in and out, and then you go in there. Yes. Cannot be illustrate over here. Right here. So we go in here. Actually, when you palpate that, you can feel the junction between the rectus and abdominis, and you can feel the oblique here. Okay. And then you go lateral to medial, and then you just slowly sink in, and you have to use some pressure here to get in there. And now I'm in here. It's normal to have it's normal to have, you can have a latent trigger point with certain symptoms, and it's normal to be tender, but it has to reproduce the pain patterns of the trigger point. Otherwise, it's just tenderness. So leave it alone.
Do you do the suicide? Do you elicit the suicide to which may signify some psoas problem?
Yeah, but it's not very specific, the suicide. When you do tests and low specificity, it's very, very low. Because you're so much interactive with other muscles and tenderness areas. So it's very low specificity and validity too. So it's not very good. You can only go for the trigger point referred pain. That's the only diagnostic criteria which is valuable. You have to reproduce the pain that the patient is experiencing. Don't guess, make sure. When we go further down and look at the other trigger points, they lie actually just underneath the inguinal ligament. If you start palpating that, they will tense up, no matter what. We have some deep structures. We've got the femoral artery nerve. We've got the male and female reproductive organs lying down here. So you actually have to get underneath them. And that's why I always like to use my ultrasound scanner, because I can follow the ESWT up to the attachment. I can see how far down it is. And normally it's about 2 or 3 centimeters thick in the top part. So you can, if you actually put the right gel pad on, you can just hit the muscle, and you won't hit the abdominal aorta or the bowels. You can go in and actually treat the trigger points without the patient tensing up. You can't do that manually. You can't do it with the injection of therapy either. It's very, very hard. You can do that then with the insertion and the lesser tuberosity, but still you've got a lot of, let's say, important tissues that you have to go through. So, if you like that, I would use the I won't, don't worry. So normally you have to use 4 or 5 centimeters on a man to get into actually where the ESWT attaches, to find the trigger point just near the attachment to the transverse process. And after palpation, you skin mark it, and you put it on here, and use the same pressure as you did when you palpated. So they have to be experienced. You start with a low dosage and find the angle, and then when it reproduces the pain the patient has, you're in the right spot. And when you use it compared to manual pressure, you'll get a total other response. The patient will really feel the whole pelvic area responding. The same thing, we have some very strong receptors in the abdominal muscles, so when you touch them, they contract automatically. So if you want to do manual therapy on them, you can fight with the patient as long as you want to. They keep on tensing up again. They are linked to the respiratory system, so you just can't make them relax there when you do manual therapy. Injectional therapy you can do because it's superficial structure, but if you want to do something non-invasive, you can do this. Just with a 5mm or 0mm gel pad, you go straight down on the abdominal area, and you'll get a beautiful referral pattern into the pelvis. Because it's such a clean way, you're actually relaxing all the structures, and you just hit the trigger points. You do the same over the inguinal ligament, because you're not treating the structure, you're treating the structures underneath. So actually you take the in the iliacus, on the inside of the pelvic rim, where you have most of the trigger points, they're very active, you nearly can't palpate them. It's very, very hard. you actually find the pelvic ring here, and you put your device just immediate to that, and you angle it like a little bit lateral, and then you can just search, and when you get the trigger point, you get the deep-seated pain too.
40? 4 cm?
I use 3 to 5 centimeters, depending on how obese they are and how much you can angle it. So I always ultrasound scan that too. I don't like to treat these areas, but I don't know how far down it is. But again, you don't cause any problems just by getting a few shocks to this energy level. Even though if you're on the femoral nerve or the lateral cutaneous femoral nerve, you'll get a nervous distribution here again. You just move the probe around, and when you find the muscle and you find the areas of the trigger point which reproduces the pelvic pain, you're in the right spot. And you're not close to any vascular things or nervous lesions. I'll take this out here. The last trigger point, which you will find often, which is also misdiagnosed as iliopsoas bursitis and tendinopathy. The long-standing tension of iliopsoas, you can find some tendinopathy-like lesions. When we scan them, we don't see very much. We see discrete thickening of the tendon, but no vascular changes. There's no inflammation in it. And we see very, very, very few real iliopsoas bursitis. If you have one, you can't move your leg. You can't walk. You have to limp. So it's, if you've got a bursitis, also if you see a bursitis, you can't walk. And you are very swollen subcutaneously. So what we do here is actually we lift the leg over the other one, like this here. Then you actually expose the iliopsoas tendon most. You put it superficially, and you find the inguinal ligament here and the adductors here. And just underneath that, on the midway, and a few centimeters down, you will find the last trigger points in the iliopsoas, just near the attachment of the tendinous muscular junction. And that also reproduces deep pelvic pain.
But here is over the femoral artery and nerve, is it?
No, it's just lateral to it. The femoral artery and nerve runs a little bit more medially. I rotate the leg out to get the tendon out here, and the artery will actually just lie medial to it. So you address it from the side here, I get it. And what you do normally is when you ultrasound scan it, you only hit below the artery. Understand? So you don't treat the artery. Here you don't. Think about this here, it's not a progressive beam, it's actually displaced. So I don't treat the superficial structures, I only treat the target zone. And the iliopsoas tendon, when it's thickened, it's between 1.5 to 2.5 centimeters if it's thickened, and you've got trigger points in the muscular tendon junction. So if you go deep, there's no problem. If you go 4-5 centimeters, you're way below the femoral artery, and it's more medial to the side. If you're on the trigger point and it reproduces the pain, you are far away from the artery. Think about it like that. And then again, it's a word of caution. Stay away from big arteries and big nerves. There's never been any complications reported, but we don't want to cause any complications. We don't know what the implications are.